distinguish that from vaccine uptake or under-immunization, which are behaviors. And I would like to point out too that a lot of the work that I have done on vaccination predated the COVID-19 pandemic, and I focused on childhood vaccination and HPV vaccination. Then I would like to discuss the work that I will be undertaking during my postdoctoral fellowship while here in South Africa, and then I would like to provide some food for thought for moving forward during these troubling times. So already before the COVID-19 pandemic, in 2019, the World Health Organization had listed vaccine hesitancy as one of the 10 threats to global health. And the reason that they did this was that, for example, measles was rising. There's a 30% increase in cases globally, despite a vaccination having been available for a very long time. In their announcement, they defined vaccine hesitancy as the reluctance or refusal to vaccinate despite the availability of vaccines. And they point to how this threatens to reverse progress that we've made in tackling vaccine preventable diseases. Although this announcement came in 2019, I'd like to point out how vaccine hesitancy or concerns about vaccination is not at all a new phenomenon. Historically, when vaccinations first started becoming a practice, and before it became accepted in the medical community and as a medical practice, Edward Jenner, who is considered one of the founding fathers of vaccination, in 1797, when first proposing vaccination against smallpox, it was met with quite a bit of resistance, both among his colleagues and among the public. So if you can see this image, we have some people who have, I don't know if you can see this, the idea at the time was to inoculate people with pustules from cowpox and then insert them in people's arms or into their body by taking some of the pus. And so some of the fears at the time were that you can see people having cows growing out of their bodies. They were concerned about what was actually going to be happening to them. So although it seems a bit strange or ridiculous, I'm sure that you can also hear, or you've probably heard or seen some of these some similar concerns about COVID-19 vaccination as it's been implemented. So just to point out that it's not new, that it's been around ever since vaccination has existed. But I will be talking about vaccine hesitancy and vaccination-related issues from a modern perspective and thinking about more recently. So already in 2014, the WHO had a strategic advisory group of experts get together to talk about vaccine hesitancy, and they defined it as a delay in acceptance or refusal of vaccination despite availability of vaccination services. Okay, so this definition since then has been, and I think rightly so, has been criticized because when we talk about vaccine hesitancy, especially if we look in this definition, it's talking about acceptance or refusal. It's often discussed as a behavior, although vaccine hesitancy, if you're hesitating about something, it's more of a psychological state. So it's not delaying or accepting, it's something where you're not sure or there's some uncertainty. Oftentimes, vaccine hesitancy has been used as an umbrella term that incorrectly includes people who have actively chosen not to vaccinate. So these are people who have decided that they are not going to vaccinate. These people aren't hesitating, they are sure of their decision. The last point is, I think, and we're really seeing this, I think, in the COVID pandemic, is that vaccine hesitancy can wrongly be used as a causal explanation for under-immunization, meaning not getting vaccinated according to the recommendations, whereas other issues such as social determinants of health, thinking about pragmatics, how easy it is to get something, access, inadequate services or policies, may actually play more important roles in uptake. So it's important that when we're talking about vaccine hesitancy, that we're not actually referring to behaviors, that we're not referring to people who have chosen not to vaccinate, and that we're not ignoring the social context of the health system in which the vaccination is being offered. I would like to further discuss this issue and point out how there are different gradients of hesitancy and how people think about vaccinations. Heidi Larson, who's one of the leaders in this field, she's a medical anthropologist, and it's interesting to think that her main specialty was thinking about rumors in health and how she ended up working on vaccine decision-making and vaccine hesitancy. So she and her team conducted a systematic review from a global perspective and found in 2014 already that there's not a universal algorithm, right? There's not a perfect recipe that will tell us if somebody is going to be vaccine hesitant, if somebody is going to not vaccinate. So they point out how the independent and relative strength of influence of each factor or variable is complex and context specific, that vaccine hesitancy varies across time, place, and vaccines. So if we just think about the COVID-19 pandemic, 5 years ago, we didn't have this pandemic. The place, if we're thinking about where the vaccine is being implemented, South Africa compared to Switzerland, where I've done my work, is not the same context. And then it depends on the vaccine. If we're talking about COVID-19 vaccine, it might have less, people might be less favorable towards this vaccine than they might be towards a vaccine that has been around for much longer. One thing that I would like to also point out is that I think, especially for public health practitioners, is that it's important to stay away from the pro and anti-vaccine dichotomy, and because a lot of these terms, they promote polarization in public discourse around vaccination. And I think we've heard a lot about anti-vaxxers, we've heard a lot about pro-vax people in the past couple of years, and this doesn't necessarily encapsulate all of the ways that people can think about vaccination, because people have a range of views of vaccination. People might be ambivalent. They're not really sure how they think. They have vaccine-specific views. They might be in favor of tetanus vaccines, but they might not be in favor of the flu vaccine, for example. Context-specific, I've talked to parents in Switzerland who, as soon as there's a pertussis outbreak or a measles outbreak in their family neighborhood, then they might be more inclined to get their children vaccinated. And then one of the things too that we need to remember is that people's views about vaccination can change over time. So if somebody right now is expressing hesitancy or they're not sure, that when, especially from a public health perspective, if we're able to engage in dialogue that acknowledges their hesitancy, but can speak to them in a way that understands them, that might change the way that they're thinking about vaccination. And then I would also too like to point to this kind of pyramid. It's a more of a visual tool that helps us think about where people might fall in a different gradient of hesitancy or way of thinking about vaccination. And I didn't create this. This comes from some Australian colleagues, but they have, at the bottom, and this is also kind of supposed to be somewhat representing the amount of the population that falls into these categories. So most people, especially, and I'm speaking in high-income Western income countries, are unquestioning acceptors. They don't have questions. They accept vaccination as the norm. They will just do it when their doctor or their healthcare provider promotes vaccination. Then you have some people who accept cautiously. They have a few concerns, then they do get the vaccination, even though they have some concerns. The hesitant, a few less of these, they might have many concerns. And then you have people who vaccinate late or selectively. They might cherry pick, only do certain vaccinations, and they might do it later than according to schedules. And then I want to point out too that the decliners of all vaccines, all the way at the very top, this is a very, very small part of the population. And in high-income Western countries, this tends to be 1% to 2% of the population. And this data comes before the pandemic. So I haven't been able to follow this, and I think we will see this over time if this number stays the same, increases or decreases. So again, the people who are 100% anti-vaccine, never, ever, ever going to vaccinate, it's a very small margin. It's 1% to 2% of the population. However, they are quite loud. They make a lot of noise, and the information that they tend to spout, it gets out there quite easily and makes us overestimate their presence. What does the social science literature say on vaccine hesitancy and how people decide about vaccination? And I'll focus on this because I come to this field as a social scientist. When I was doing the work in Switzerland, thinking about where people get their information about vaccination and what influences them, we really see a strong correlation that influences about how people make vaccination-related decisions come from personal, social, and cultural networks. And what this means is that, in general, what we've seen is that if you have more people in your social networks that are vaccinating, the more likely it is that you will vaccinate. The opposite is also true. The more people that you have in your networks that either hesitate or refuse vaccination, the more likely it is that that influence will rub off on you and that you will hesitate or not vaccinate. We do see this, and I think this will be important for the work that I'll be doing here. We do see a divergence in sociological variables related to under-immunization, so not getting vaccinated according to the recommendations. This comes from Jennifer Reich, who's an American sociologist who has worked on vaccine refusal. She points to how, when we think about the medical outcome of whether or not people vaccinate or not, so thinking about vaccine uptake, she points at two different groups of people where this outcome might be the same of not getting vaccinated. So she points to white, educated, upper middle class women, and she points to Black, less educated, impoverished women in the United States. Whereas the outcome of uptake in these two groups, and not everybody in the groups, but certain subsections of these groups, the outcome is the same of not getting vaccinated. What she points to, however, is that in the first group, the white, educated, upper middle class women, this tends to be a decision that is a choice, right? So these people actively choose not to get their children vaccinated. Whereas in the second group, this tends to be non-uptake due to failures of the healthcare system or not getting adequate access to medical care. So I think that's something that really intrigued me when I was doing this work in Switzerland, is that typically in the first group, these are variables that are often associated with better health outcomes. Whereas in the case of vaccination, what we see with the vaccine hesitancy, that this is one instance where when you come from a position of privilege, that you might not be making decisions that are favorable for your health. One other area that's important to think about is medical practitioners' influence. And when this is actually one of the things that we see is that healthcare professionals and doctors typically tend to have the most influence over how people make their healthcare decisions, especially when it comes to vaccination. We see that trust between providers and their patients and thinking about good relationships tend to be very, very key factors about how people make their decisions. In general, if you trust your provider, you trust their recommendations. Other important factors include the amount of time that they're able to spend on you, the type of information they offer you, and the communication styles. This last point is something that is becoming more and more pressing as we move on with this pandemic, thinking about the multitude of available information and having too much information leads people to be indecisive. So when we have information overload, that it brings people to not really know exactly how to think about this. And we see this, we've seen this ever since the pandemic has started, which brought the World Health Organization to begin talking about what they refer to as an infodemic. And here they describe this on their website as too much information, which includes false or misleading information in both digital and physical environments during a disease outbreak. It can cause confusion and risk-taking behaviors that can harm health. So this is a struggle that we continue to deal with when it comes to not only vaccination, but other health-related information. So I just want us to be aware of that, and I thought I would bring that up. This is what I just wanted to point out some of where I'm coming from before coming to South Africa and the type of work that I did in Switzerland. And this was a lot of my PhD related work. So we did a study, it was a protocol talking about determinants of vaccine hesitancy in Switzerland, and thinking about our study design, we did both qualitative and quantitative methods. The type of work that I've done, this was a study where we focused on complementary and alternative medicine and the providers who offer these types of services and how they talk about vaccination with their patients. On the other hand, we talk to classical biomedical doctors, and so these are your traditional pediatricians or GPs who don't have any training in complementary alternative medicine. And what was interesting in this study was that often these providers we saw were quite frustrated when it came to dealing with vaccine hesitant or vaccine refusing patients, and it brought them to call these patients problem patients, refer to them as difficult, and not knowing what to do. There were quite a few dilemmas they faced, and some of them considered themselves as failures, and there were considerations about their reputations as healthcare providers when they had to deal with patients who weren't adhering to vaccination schedules. This last study focused on parents' perspectives, and it really points to, at least in the Swiss context, how issues of trust, affect, or how people are feeling about the medical consultation and choice in parents' vaccination decision-making and healthcare provider selection in Switzerland. So here, what we really found out, it wasn't so much the medical information that was provided, but it was relational aspects of patient-provider interactions that had a role to play in how parents were thinking about vaccination for their children. So that was thinking about vaccine hesitancy and where I'm coming from before COVID-19. And I want to think about vaccine hesitancy and uptake and COVID-19. So where are we at now and what can we say? So the next few slides are going to be focusing on these types of questions. So already thinking about global vaccine hesitancy before the pandemic, and I talked about this with Heidi Larson. We already knew she wrote this book that came out right at the beginning of the pandemic, and she had to rewrite the foreword of the book because COVID-19 struck, and then she very quickly wrote a new introduction to this book. We had a few references on how to deal with vaccine hesitancy on a global perspective. And then we saw a few publications start coming out at the beginning of the pandemic. And a lot of these studies were thinking about anticipating a COVID-19 vaccine as it arrives and what we're going to do about it. So we already see, how do we restore confidence in vaccines when COVID-19 is happening, thinking about vaccine mandates coming from Australia. And then this is an anticipatory study in France. What I do want to talk about, so that's thinking about hesitancy, which is quite difficult to measure from a global perspective. What I do want to focus on is thinking about the actual uptake or the behavior of whether or not people are getting vaccinated. So I thought I would pull this up. And of course, there are better websites, but I just like the graphics that the New York Times is able to give. So I wanted to show this from the Tracking Coronavirus Vaccination Around the World. This shows a map of where we're at globally thinking about vaccine uptake for COVID-19. And so if we look at just receiving one dose on this map, we see the green tends to be higher uptake. Oops, I skipped a slide. So we see Australia, China, Canada, parts of South America, Spain, Portugal, with quite high levels of the population receiving at least one dose. When we have the darker red and these tones down here, we see a lot of African countries and sub-Saharan African countries with lower portions of the population having received at least one dose of the vaccine. This is just to give a percentage of where we're at in South Africa. And this, I was looking at the South African data yesterday, and this is coming from Our World in Data. And here it's showing that we're at 32% in South Africa, with almost all of that level getting fully vaccinated and then only partially vaccinated. I was looking at the data yesterday in South Africa, and that data was actually pointing to the adult population. And according to what I saw here in South Africa and those platforms, we were at about 50%. And so I'm not sure if for this data, if that included children or not. But so depending on the sources and how we're measuring this, the numbers differ slightly. But here we're seeing actually that South Africa is lagging behind quite a few countries in terms of coverage. When it comes to low and middle income countries, what we're seeing from a systematic review of vaccine acceptance rates, we see that more studies are recommended to address the scope of COVID-19 vaccine hesitancy. We need more studies in the Middle East, North Africa, Sub-Saharan Africa, Eastern Europe, Central Asia, Middle and South America. Addressing the scope of vaccine hesitancy about COVID in various countries is recommended as an initial step for building trust in these vaccination efforts. So I've been talking quite a bit already, and now I'm going to get into what I would like to do while I'm here. And so what I will be doing is focusing on COVID-19 vaccination rollout in the Western Cape, South Africa. And so the focus on Western Cape allows me to be a little bit more local, a little bit more focused. And I would like to think about how people's vaccination, and this is COVID-19, routine childhood, HPV, and influenza, how these attitudes and uptake are linked to how people feel that the officials handled the COVID-19 crisis, their vaccine hesitancy in relationship to each vaccine, and levels of trust or distrust in science, health workers, government, and the pharmaceutical industry. So a lot of these themes are quite prevalent already in the vaccine hesitancy literature, wondering about COVID-19 and how that changes maybe how people are thinking about vaccination. I would also like to examine COVID-19 vaccine rollout from the perspectives of the implementers, so public health or governmental officials, with a context focus on the role of the state and affiliated actors in creating and implementing vaccination programming and policy. How will we specifically do this? One of the parts of my study is I will be conducting a scoping review, and this will involve looking at literature on COVID-19 vaccine hesitancy and the social determinants of vaccine access in low and middle income countries, with a particular focus on sub-Saharan Africa and South Africa. This is a project that I'm co-leading with Dr. Jennifer Gataiga, who is on this call, and the project is entitled Disentangling Social Inequalities Around Access and Vaccine Hesitancy for COVID-19 Vaccine. So what we will specifically be looking at is to what extent do access issues or inequalities play a role in COVID-19 vaccine uptake, especially in these contexts? And then to what extent does vaccine hesitancy play a role in COVID-19 vaccine uptake? So is it access or vaccine hesitancy or a combination? The next part, and this might seem a bit counterintuitive, but one of the things that I did when I first came to Cape Town is I started talking to people who've been working in the vaccination space here. And I got in touch with Sarah Cooper, who does a lot of qualitative evidence synthesis and systematic reviews for the Cochrane Group. And what she told me and what was astonishing to her is that in South Africa, there has never really been a study looking at how privileged people, so here I define privilege as people as being part of the stable middle class or the elite part of the population, how they think about vaccination. And I would like to have a specific study component looking at this group of individuals. And this is interesting because when we see where most of the vaccine hesitancy literature has been done, especially in other countries, it tends to be higher income countries, Western countries, and we see that this literature does focus on people coming from positions of privilege. And Jennifer Reich, who I mentioned before, does criticize vaccine hesitant individuals or vaccine refusers by pointing to how they are able to do so because they come from a position of privilege. So these specific questions will look at, how does this population make vaccination decisions? Who and what are their sources of information? How do they interact with information to them that's available to them about disease and vaccination? How do they feel about health authorities' handling of the pandemic? How do they describe their interactions with various health systems or institutions in obtaining vaccine information? And then how has the COVID-19 pandemic brought them to think about vaccination differently? And if so, how? Finally, the last component, and I'll be wrapping up soon so that we have some time to discuss and see what you have to think about this study, is a qualitative study looking at health authorities, government officials, and healthcare professionals working on COVID-19 vaccine rollout efforts in the Western Cape. So this study is inspired by some of the work that I did in Geneva, my former supervisor and mentor, Mathilde Bourrier, who looked at managing the global health responses to epidemics. She was working on the Ebola and H1N1 crises and thinking about the actual responders, the people in charge of implementing the response to these epidemics. So this part of the study is guided by the assumption that these measures are not created in a vacuum and that they are negotiated through social processes that involve particular social constraints. So I would like to conduct either focus group discussions or qualitative interviews with people in the Western Cape who've been involved in implementing the COVID-19 vaccine rollout. So thinking about how what the strategies have been, especially in times of uncertainty with shifting evidence over time. How do these actors make decisions about vaccination implementation, and what types of evidence are their decisions based upon? How do they strategize in creating public messaging around COVID-19 vaccine? How do they establish where to allocate resource and focus efforts? And I think that'll be a big issue thinking about the Western Cape context. How do they attempt to maintain public trust and deal with distrust during the rollout? And then from their perspectives, what are the successes and failures of the rollout so far? And where are there gaps in knowledge and practice with room for improvement? And of course, I would like to just point out that I have not yet begun the data collection, and I look forward to doing so. I'm in the process of getting approval from ATREC, and hopefully we'll have the approval soon so that I can begin starting some data collection. And then just to conclude, some of the things that I would like to point to based upon my previous work, not based upon anything that I've done in South Africa so far, but what we've seen in other contexts when it comes to vaccination programming, is that clear guidance from the health authorities and public health authorities is essential. That maintaining trust in public health officials, scientists, and healthcare professionals is also fundamental. If we want people to adhere to the programs that we're putting out there, that we need people to trust us. Part of this involves having clear, transparent communication about what we know and what we cannot yet know. And then also, in order to have high quality, equitable implementation programs, we need to have high quality interdisciplinary research and implementation approaches so that we can understand how individuals make vaccine related decisions and how the different parts of the system work together. These types of things, it sounds very simple when I put it out like there, but these types of efforts they need resource, they need time, they need energy, and they need money. And I will plug for strong social science researchers. I'm a social scientist, so I'm biased in this effort, but we need strong social science researchers who can engage effectively in transdisciplinary settings, and also stakeholders who are willing to listen to social science researchers, but also social science researchers need to listen to other types of researchers and where they're coming from a disciplinary perspective and what types of evidence they look at. So I will stop there, and I thank you for listening. I'd appreciate any thoughts, comments, or questions about the study that I proposed very quickly. I would also appreciate any potential collaborations with researchers here who are working on projects related to the vaccination rollout. If you'd like, you really feel free to get in touch. I'm looking forward to hearing more about what's going on here. I have my email address here, and I'm quite easy to get in touch with. I will then stop sharing my screen, and I open up the floor to you. I just have to figure out how to stop sharing my screen. There we go.
Thank you so much, Mike, for a fantastic presentation. It gave a really nice background to the topic, and I think a good overview of what you're planning to do. And I think you posed quite a few interesting points, and I think there will be lots of conversation, I hope. So is there anyone that would like to start with asking a question? There's not a very large group, so you can either raise your hand or just unmute yourself. Peter, nice to see your face. Go ahead.
Hi, Michael. Hi, Alicia. Yeah, good to touch base again. Thanks very much indeed for a very nice presentation. I think you touched pretty well on all the basic issues around vaccine hesitancy. But then again, you've worked on that for a long time now, haven't you? It was nice also to see how you unpacked, the different influential factors in a very concise way. Speaking about the different segments of the population and the ones that you need to focus on in terms of rollout of vaccination, I would say that maybe the anti-vax proportion in South Africa is probably slightly bigger than, I'm not sure about 1 to 2%, but it seems based on what we see in the surveys, the large national surveys, that there's like that resistant part of almost nearing 10% almost, that is like very resistant over in the different waves of several surveys. There's the NITSCRAM survey, there's the CVAX COVID-19 vaccine surveys, the University of Johannesburg. So this, I'm sure that you've tapped into all that, but it's very nice to see that and that you intend to plan doing very thorough social science research on this aspect. I'm not a social scientist, you know that. We've spoken before. We've looked at the vaccine hesitancy amongst people with the NCDs and the healthcare workers in the Western Cape. And interestingly enough, based on our data, preliminary data analysis, we also identified the issue of trust as a very central theme in everything that happens around that sort of decision making in that space. So trust and beliefs seem to play a prominent role. What we queried, however, and I would like your opinion on that, is if you found something in the, also in international literature or your previous work on that, is the role of religion as a personal belief system, or B, as what we may have found, for example, here in the Western Cape, a driver or an influencer, as you know, in parallel to, you know, social influences, almost like a religious influences that seem to play a key role in certain communities, and that sort of also are partly responsible for creating that mixed pattern and a very, you know, heterogeneous sort of a tapestry of what is going on in terms of vaccination decision making, and also what the Western Cape and even Keith Clutie has described as we need to go for somehow a sort of hotspot strategy in terms of you know, delivering tailored messages because it's so much contextualized and it's so complicated and heterogeneous that one would have to look into that. But so I would like to hear about your idea about the space or the place or importance of religion in all of this. I'll just stop here.
Sure. Thank you so much, Peter. I'm happy to see you again. So I'm not surprised by the prevalence of trust as being an issue. And so what I think it's funny because a lot of the colleagues I had before coming to South Africa was like, oh, it's going to be so exotic compared to, you know, the stuff that you've done in Switzerland. But honestly, the reasons that people hesitate around vaccination are quite similar. I mean, like most people, they're concerned about safety, they're concerned about efficacy, and they're concerned about necessity of vaccination. And one of the mediators of that is trust. And trust can come from the different messengers that can be, you know, healthcare professionals. What I have seen very little in my previous work in Switzerland has been the issue of religion. But one example of where trust through religious leaders that comes to mind was a few years ago that measles was spreading quite heavily throughout the US. And this was in Orthodox Jewish communities. I think in New York, there was quite a resurgence because in these communities, the leaders were recommending that the children don't get vaccinated against measles. But one of the things here that I've seen locally, just kind of very informally about religion, is that there are some efforts to get out into some of the more impoverished areas or in the townships through what's called the vaccitaxis, or working with the local health committees. And just kind of informally talking to people working in health committees, I saw the issue of religion coming up because the health committees do recognize, and these are volunteers working on making sure that the vaccination can be available and that the local population and communities can understand why vaccination is important, is that they understood the need to go to these messengers of trust, and they went to the local religious leaders, and they went to the churches or the mosques or, you know, whatever the religious spaces are, and they talked to these leaders and made sure that vaccination services could be offered near, in, or around the places of worship. So I think that's something that is we shouldn't overlook, and we've seen this time and time again, and not just in vaccination, but any kind of rollout efforts that require mass adherence. Is if you go through local leaders that are trusted, or people who are trusted messengers, that I think health efforts tend to roll out more smoothly. So really, thank you for pointing to that, and it's not something that I should overlook. And I'm happy that you pointed out to me, because I think based on my previous experiences, I probably would have overlooked religion.
Thanks, Peter. Thanks, Mike. Are there any other questions? Any hands? I didn't see any. Khadija, go ahead.
Hi, Michael. I really love the presentation. It kind of explained the nuances that I also experienced when speaking to communities about vaccine hesitancy. where there is a differentiation between being hesitant and actually making the decision not to take the vaccination. And I think therein lies the nuance in what you're trying to explore. What are the factors that causes this decision making, and how this is influenced by different areas that normally influences people. I would actually like to know why you have chosen Africa or the Western Cape in particular for the study. I ask because in different contexts, other countries, there's definitely rationale when coming to making decisions. And I've noticed that in South Africa, it's a very huge political component that sways or influences people's decision making because of what you mentioned, the lack of trust, right? And there are also strong religious perspectives because in some communities, like the Muslim community, there was concerns whether there was pork ingredients within the vaccines and that made them hesitant to take the vaccinations. And then also our history with, other vaccinations, like you mentioned, HPV, HIV and AIDS, and they were different circumstances. So why is Africa or the Western Cape what of particular interest to you? And will you involve some NGOs within understanding how people interact with information presented to them about COVID-19? Because there is still a a belief system within communities that COVID-19 doesn't exist, that it was something created by the government to control people's actions and behaviors, right? So I know with my parents that don't want to get vaccinated because they believe that Jacob Zuma is within a conspiracy trying to control people's minds. And then there's this whole 5G, mythology on the Cape Flats where people believe that they're going to be monitored by the government. And my last question is also, how do you envision the study to make a contribution or influence public health responses? Thank you.
Okay.
Sorry.
All right.
Thanks,
Thank you,
Khadija.
Khadija. There was quite a bit of background noise. So I think I will address what I'm sure that I think I understood. So the first question of why I chose South Africa. So this is more of a question of serendipity and also kind of circumstance. So when I applied for this funding, I had applied to go to Perth in Australia to work on the Australian context and how the COVID-19 vaccine rollout was going to be going on in Australia. But because of immigration reasons, I was not able to go to Australia. So I rapidly got in touch with Lucia and then was able to set up a kind of a plan B for me to come to South Africa. So I came here very, very naively, very, very much not knowing anything about the South African context. So I'm really working here. Just it's out of kind of like a random chance of destiny. But I do think I'm quite happy because it does confront me with these issues of really thinking about rollout of vaccination in context of scarce resources in some of these communities. So I'm yeah, that's kind of why, and what I found interesting and where I'm at is kind of this tension of thinking about access versus hesitancy. And I think that'll be one of the main areas that I'm looking at. The second question, I can't remember maybe I missed it.
I think there was something around mistrust as well, but particularly around the government.
Yes. And so I think the mistrust around the government, that is something that we see, we've seen before the pandemic, but I also think it's something to keep an eye on as we go forward. And just in some of and I'll see that also probably in the privileged part of this study, is just in also informal discussions I've had with people since I moved here. I've heard so many kind of just random things about, the hesitancy towards the vaccination has been related to issues of people thinking the government trying to control us. And when I push a bit further and ask, what are they trying to control us to do? I don't always get really like clear, straightforward answers. So I get a sense from those types of discussions that there's just a general miscontent about other issues that aren't related to vaccination specifically. It might be frustrations about COVID-19 measures, it might be economic concerns. But I think what we see in some of these mistrust areas is that vaccination can sometimes become the scapegoat for a lot of other issues. And then just the last point about what kind of contributions I think we can do with this work. I think oftentimes in the space of vaccine hesitancy research is a lot of the efforts tend to focus on lay people understandings or community understandings. And I think sometimes this research goes in the direction of let's find out what people think about vaccination and kind of think about their false beliefs or why they're wrong. Whereas I think the contribution of if you come in from the perspective of where are people getting their information, how do they interact with it, and then also seeing how oftentimes I think we overlook the implementers and what their assumptions are, and then how they're making those decisions. So a lot of the work that I like to do, and that's what I did in Switzerland, was looking not from only parent perspectives, but also looking from provider perspectives and then public health official perspectives. Because if they're operating under assumptions or from different levels of constraints, maybe they're not aware of what's going on the ground. So I think one of the contributions that I can bring is thinking about not only what people think at a community perspective, but how programs are implemented and how the different parts of the puzzle look together. And what I tend to find is that the implementers are quite interested in this type of work because it is almost like an evaluation that they can get and then get fed back to them. So they would engage and they would likely read the work that comes out of this type of research.
Thanks, Mike. Are there any other questions? We still have a little bit of time.
Could I ask a question or make
Go
a comment?
ahead, Jennifer. Yes, please.
So as you know, for those we've been working together, I'm really excited about this study and looking forward to it, and particularly interested in just issues around the role of the context. That when you take that context does, is quite a big, has a role to play in the whole dynamic and all of that. And as I was thinking about some of the work we're going to do, I just wondered about the role of ourselves, your positionality as coming in as an outsider. Well, I'm also an outsider, I'm from Kenya, right? For example, but, having different, coming from as an outsider into the South African context, what particular influence that might have on the sort of, data and interactions that might be had with the local people. And so just thinking around that issue of positionality, and if you've thought about that, age may also be a factor. When you're talking to different kinds of people, maybe older people, younger people, but just wondering if that is something that is on your back burner at least.
Yes. Thank you so much for that question, Jennifer. Reflexivity and how I position myself in this research. This has been something that I've been confronted with ever since I started working in the vaccination space, because a lot of, especially when you're talking to people who are hesitant or maybe have kind of anti-vaccine attitudes, they can be suspicious about what my intentions are as a researcher of, I'm going to try and learn things that will convince them to vaccinate later. So this is something that's been at the front of my thoughts. And oftentimes what I tell people in these instances, I'm working as a social scientist. I would like to understand, people's actions, their behaviors, and their thinking and about an issue that is of social importance. But also thinking about my positionality as a white American man in South Africa, and what that means for the data collection that I will be doing. This is where I'm quite happy to work and collaborate with other people here who know the context much better than me, because I think I come with maybe some misunderstandings or some naive understandings of how things are done locally. And so I will depend and I will ask people working here locally so that I'm not just making blunders or mistakes as I move forward with this work. Though sometimes I've noticed that as an outsider that when I did my work in Switzerland, I'm a non-native French speaker and I'm not from Switzerland, but I did often get more detailed responses to my questions because people wanted to make sure that I fully understood some of the subtleties and nuances. So it can be a bit of a double-edged sword where you do get extra information, but you also have to kind of be cautious about that extra information of how people are presenting themselves to you.
Oh, thanks, Mike. That helps, and I also like the interdisciplinary approach. And thank you for making a distinction between knowledge, attitudes, and beliefs, say the psychologists. Yes. So very keen on that as well. Don't lump everything up as behavior change. It may not be. Thanks.
Yes.
Thanks, Jennifer. That's great. Khadija, I see your hand, but I'm just wondering if anyone else, we've only got a few more minutes, if anyone else who hasn't had a chance to speak yet has any questions. Okay, I don't have that. Khadija, do you want to go ahead? It needs to be super short because we've got 2 minutes.
No, it's okay. I can find Michael afterwards and have this discussion with him. It's okay.
Okay, super. All right. So if I'm assuming that there are no other hands or comments, I think we can draw this to a close. Thank you so much, Mike, for a really interesting presentation. It was great to hear about what you're doing, and I think it was a useful discussion. And we are excited to hear the results this time next year. So we'll put you in the diary for now, and yeah, looking forward to hearing more about what you do and to see what happens. And thank you very much for being the person to step up for the first meeting of the year. And thank you everybody for attending, and I hope you have a good week, the rest of your week, and look forward to seeing you all next week for the next noon meeting. Thanks, Mike,
right.
again.
Thank you
Thanks,
so
everybody.
much. Bye-bye.
All right, bye.
Thank you.
Thank you so much. Great session. Bye.
Bye-bye. Thank you.